Hi everyone, thank you very much for being with us today, and thank you to Vanessa for that very warm introduction. So what I'm going to do is to talk with you about some of the things that interest me, particularly what is sex, how cancer and its treatment can impact sexual function, how each of us respond to that, sometimes in quite different ways. I'm going to let you in on some secrets about the health professionals and their response to sex and talking about it, and some of the things that you might actually find helpful in dealing with sexual changes that you have experienced. So just so you know a little bit about me, because we are going to be talking about things that are fairly intimate. I grew up in northwest New South Wales in a very small village and moved to Sydney to go to university, where I still am, living just around the corner from where the Priscilla bus took off. I share my home with my partner and our two adolescent young adult sons, who are really not particularly impressed that their mother trots around the country and the world talking about sex. So that's a good point for us to move on to talking about what is sex and sexuality. So sexuality is not just sex, it's not just about intimacy, it's not just about intimacy or sexual intercourse. It's about who you are. It's how you see yourself, and how you express yourself sexually and your sexual feelings for others. It's an expression of intimacy, but it's very much part of our self-identity, and that can be different for each one of us. Everyone has their individual sexuality and the way that they express that. And I think it's really important to remember when we're talking about sexual health and sexual dysfunction that sexual health really is not just the absence of sexual dysfunction or problem. It's actually about a state of sexual well-being and wholeness, I guess. And that's one of the things that sometimes can be quite challenging in the cancer context. Before we get too far into this, I also just wanted to make sure that everyone's clear and understands that I'm not suggesting that everybody has to be interested in sex. It's not a requirement for living, and I'm not making any judgments about that. So my job here really is to talk about if sex is a concern for you and you want to think and talk more about it, then there are places that you can go to seek help for that. So my job is to really talk to us about that rather than tell you that you should be thinking about sex all the time. So what we know really is that sexual difficulties or dysfunction are very common, with around 43% of the general population reporting some kinds of sexual concern. So it's not just a problem for people who are unwell or have had a diagnosis of cancer or some other illness. But we do know that somewhere between 30 and 100% of women who have had ovarian cancer diagnosis will talk about disruption and trouble with sexual function and sexuality. Some of the reasons, some people may find sex painful, and that can be a result of some of the treatments that you may have experienced. So, particularly related to scarring or shortening of the vagina. Vaginal dryness is very common post-cancer treatment, and sometimes there can be an emotional component where you fear pain as part of sexual intercourse, and that really exacerbates the experience and increases the pain intensity. Some people talk about having trouble climaxing, and that can also be related to your medical treatment, particularly if you've had surgery in the pelvic region. That can really affect the nerve endings and the nerve connections around the genital areas. Antidepressant medication can make a difference and can suppress libido. Fatigue can be a real suppressant, and how you're feeling emotionally is potentially a problem. One of the great things about cancer is that we're starting to talk about these things, whereas in other illnesses where it's not just a problem for cancer, it's a problem in other areas, and we really just tend to sort of ignore it or not discuss it as health professionals. And I think it's really important for us to remember that. One of the other things that I wanted to highlight is that sexual function or illness and treatment can affect pretty much every aspect of the human sexual response cycle. So you can see here on this graph is the human response cycle, which starts with desire, moves up into arousal, up into orgasm, and then resolution and satisfaction. But what we know is that our altered perceptions of ourselves, our body image changes, anxiety, depression, and many other things can impact on our desire to have sex. And particularly in women after ovarian cancer, around 25 to, or sort of a quarter to almost two-thirds, talk about no or low sexual desire. So that's a very common experience that people have. And somewhere between a quarter and, again, a similar number have difficulty with arousal or lubrication. Again, around a third will have problems with orgasm, and somewhere between 30 and 40% will talk about pain with intercourse. And unlike other areas or in after cancer, a cancer diagnosis, sexual function is something that sometimes deteriorates or gets worse over time rather than better. So we really do need to deal with the issues if they're there. And we also know that around a third to a half of people impacted by a cancer diagnosis will become sexually inactive after their diagnosis. And that sometimes that can be associated then with a poorer quality of life and depressed mood. And sex consistently ranks among one of the top 5 unmet needs that cancer survivors report. So they're all things that we can be, conscious of and aware of. And again, just talking through these things, so we know that anxiety and depression or hormonal imbalances, or particularly peripheral neuropathy, can impact on arousal. And anxiety and altered sensations can impact on orgasm. And sometimes people will experience postcoital bleeding or pain, and that really contributes very much to reduced sexual enjoyment. But there are lots of things that we don't like to talk about, and sex is definitely one of them. And one of the things that comes up quite frequently is the stigma associated with sex and sexual function. Stigma is a mark of disgrace that's associated with particular circumstances or a quality or an individual. And sometimes the things that drive us to avoid talking about things is the fear that we're actually going to create some kind of disapproval or some kind of revulsion, or disgust response in someone else. And that can be really unpleasant to sit on the other side of the table if someone's responding to you in a way that makes you feel stigmatized. So I think we tend to try and avoid these conversations because you're never sure of the response that you're going to get, because sex is so much tied up with taboo kinds of conversation, social taboos. I think I've probably talked enough about stigma, really, other than to say that once you start feeling that there is stigma, that you are experiencing stigma, it can be really reinforcing, and it can be a strong message to not raise these topics again. So I mentioned to you earlier that I was going to tell you a little secret about health professionals. Well, many of them, and in fact I probably would say most, are not comfortable with talking about intimacy and sex with their patients. They find it really difficult. They're particularly worried that they're not going to have the answers that you need. They also think that maybe they don't know where to refer you for additional support. And most of them are not trained in sex therapy and have little interest or expertise in that area, plus the workload of cancer centres. They have a tendency to really focus on fixable problems rather than things that they're not sure about. So really devaluing the role of talking or sharing as a therapeutic tool. So they may not ask, and you often as patients or people in the system pick up on their discomfort, and that becomes a barrier to you asking them again. So I think one of the key messages I think that we need to take away as individuals is the permission to actually start asking health professionals about these things and starting the conversation maybe with I'm not sure if you're going to be able to help me with this, but maybe we could work out where I could go for advice. So taking the onus off them to know everything. I think we also quite commonly have some pretty unrealistic expectations about sex, and here we're calling them sex expectations. And these can be things like there's only one way to have sex, I've had some good years and now the sex is over, and a range of other things. And I think what's kind of key to this is that it's underpinned by the idea that there's only one way to have sex, and that that there's a very strong emphasis on penetrative sex as being the most important or the only way that you can engage in sexual activity. But there are lots of other things that can counter those unrealistic expectations. that particularly relate to that sex can still feel good. You don't have to orgasm to feel satisfied, and that sex can be part of your life in all sorts of different ways. And I think one of the things that people find really challenging is not being able to be spontaneous. So there can be quite a lot of fun in planning for sex as opposed to expecting it to occur spontaneously. So there's some things to sort of keep in mind as challenges to the way that we think about things. When we did some work with cancer survivors, the key thing that we learned from them was that communication is incredibly important. In a survey that we did, it really highlighted the importance of communication and that people felt a really strong need for self-guided communication skills training to talk about sexual concerns. And I think that's one of the challenges that we maybe underestimate is that when you've got a healthy, happy sexual relationship, or that's been your experience previously, you may not have a dialogue or a language to share those concerns. And so one of the things that you're doing is you're navigating this new changed body and world that you're experiencing is actually then having to start having conversations with partners or potential partners that you've never had to consider before. And that can be quite a difficult transition and a difficult thing to do. People told us particularly that the things that made it difficult to talk about sex were changes in their relationship perceptions, identity conflicts and not knowing what to call themselves, challenges to masculinity or femininity, and their sexual self-efficacy, so how confident they felt that they could actually manage these things. The things that we know help really are facilitating communication with partners, where there is a physical problem to treat that, or a physical or a psychological or a social problem, to really address that issue rather than letting it ride, and trying to minimise the effects of anatomical changes and provide symptom relief and so on. And particularly providing some information and advice about alternative methods for engaging in intimacy or giving and receiving pleasure. And sometimes people really would like to seek additional support from specialist services. So some of the things that we know are helpful for particularly female genital pain are the use of vaginal moisturisers. There are non-hormonal over-the-counter products that are available, but they need to be used regularly in order to be effective. And I think that's one of the things that's really challenging sometimes about changing sexual function is that some of these things we really need to plan to use on a regular basis, and that may take some time before we're actually ready to engage in sexual intimacy even after we're using them. Personal lubricants are also available. There's liquids and gels that are applied to the genital area to minimise dryness and pain during sexual activity. Anyone that's had pelvic radiotherapy may have seen vaginal dilators and been advised to use them, but they're particularly useful to try and make sure that the vagina stays elastic and is still functioning well. But they're best used after the vagina's been fully healed, which is about 4 or 6 weeks after treatment ends. Kegel exercises, I can't say enough about. They're really a very effective way of trying to managing changes in the genital region, particularly. They teach pelvic control, which will help you relax your vagina at different times, and can particularly help to release tension and the vagina before sex, so it's less painful. It increases the pelvic floor strength, which can also increase arousal and the ability to sort of focus on the pleasure of sex. And partners can sometimes feel vaginal movements as well. So those things are all positive. But I have to say, for those of you who have male partners, then you might want to suggest that they engage in Kegel exercises because it works really well for them as well. And it's effective in increasing erections as well. So other things that we can do to try and avoid pain or options to minimise pain during sex is to plan for that when you feel less pain. So if you take pain medication, try and take that ahead of time so it's already effective before you start your sexual activity and intimacy. Focus on the feelings that you have about excitement and connection with your partner, so playful touching, non-coital sexual activity. So as I said earlier, we've got this really big focus in our culture on penetrative sex as being the only thing that can happen, but you can experience a great deal of intimacy and pleasure just by focusing on, gentle touching and one of the strategies that we can use sometimes to re-establish intimate relationships is that sensate focus approach, where you actually agree to not engage in sexual intercourse or achieving orgasm, but to really focus on all of the erogenous areas of the body that can give you pleasure just by gentle touching. Trying different positions can be really helpful. Gentle touching. Trying different positions can be really helpful. So working out what works for you. So as we move through life, things change quite a lot, and this is one of the things that's really useful to consider as well. Psychological interventions can help, particularly focusing on intimacy and the physical connection that you have with people, but not necessarily sexual intercourse. And definitely communication skills training to talk to partners, helping talk to partners and just being able to express what we need out loud. There are barriers, though, to uptake and retention of psychological interventions. Often people are not aware that there are available resources or can't find a person that's happy to talk to them about these things. They lack referral. And there are some levels of embarrassment either from the patients or from the providers in having these conversations, or a lack of engagement from either or both partners who are involved in the discussion. And I think we probably are really not good at paying attention to partners. Their sexual needs or their needs more broadly even are not necessarily included or assessed as part of a cancer experience. So really, in summary, I just wanted to really emphasise that sexual concerns are common and they're real. Healthcare professionals may not make it easy for you to talk about sex, but there are interventions available that really can help to address some of these concerns. And sometimes a successful sexual relationship is really about redefining sex, and it's always about being able to communicate your needs. So I'm looking forward to answering questions during the rest of this afternoon. Thank you.
Thank you very much, Dr. Dhillon.
Pleasure.
Am I on air? Yes. Thank you very much, Dr. Dhillon, for that valuable information and for talking about issues that really a lot of people find very difficult to talk about. So we really, really appreciate it. So we do have one question for you that's come up. And somebody has said, I feel like my partner is no longer attracted to me as he no longer initiates sex. How can I bring this up?
Mm-hmm. So I think that's something that is a very common experience for people after a cancer diagnosis. It can be really challenging to engage around that. And I think my strongest statement about this is really that until you ask, you don't know what's really going on in his head. So, a partner in that situation may be feeling as though they don't want to pressure their partner. They may be really willing to re-engage in sex, but not sure how to go about doing that, and also not sure about how to raise it themselves. So I think if people have concerns about that, then I would say if you're feeling strong enough and confident enough, then I would raise those issues directly. But I guess my one concern would be that sometimes relationships do change dramatically as a result of these sorts of life-changing experiences. So you do need to be prepared and have a safety net around you in case that conversation doesn't go the way that you expect it to or maybe want it to. So having some support close by, the people that you can trust that may actually help in the immediate aftermath of a conversation that goes more difficultly. But I guess our more common experience is that it's fear on the side of the partners to not wanting to pressure someone who's had a cancer experience and really just trying to be careful of them. And so once you start to say it's okay, we just might need to think about how we do this a little bit differently, that can really break the ice.
Yeah, thank you very much. And we've just had somebody write in and say, I find my partner is often aroused and I'm not meeting his needs as I don't feel the desire, and I feel pressured to be sexually active more often.
Yeah, and I guess, again, I think it really comes down to those conversations and being able to be honest about that. And so whether or not mutual, masturbation or other sorts of sexual activities would be something that you would be willing to engage in with your partner, that might be a strategy. And I guess it depends a little bit on how much energy you have to be giving to other people at this point. So I guess my other concern is that lots of times we're just really tired after, in life anyway, and then particularly after having had a cancer diagnosis and treatment, that fatigue that just sort of sits with you sometimes can be really just push all of that libido down so much that it's just very hard to reach. And again, I think it's a matter of being able to communicate and be honest about that and see whether there are ways that you might be able to together address both of your needs in that moment.
Yeah, thank you very much, Dr. Dhillon. Really appreciate your time and all that valuable information.